Hi, I'm Patrick Dillon, and I'm a medical oncologist at the University of Virginia, and I'm pleased to join you today to discuss a clinical trial of focused ultrasound with low-dose gemcitabine to augment immune control of early-stage breast cancer. This is exciting because it takes a clinical observation that was explored in the lab and then brought back to the bedside in terms of a new clinical trial. My disclosures are shown here, and other than participation in clinical trials, I have no relevant disclosures. The background for this project is that breast cancer obviously remains the most common non-skin cancer in women and the #2 cause of cancer mortality in women in the United States, and metastatic disease is incurable, so of course we need more effective and less toxic treatment options in the early stage of disease. Now, focused ultrasound ablation obviously is non-invasive and certainly delivers thermal and mechanical tissue injuries, but more importantly today, it induces immune responses in those thermally damaged tissues by means of heat shock protein responses, cytokine release, dendritic cell maturation and migration, T and NK cell activation and trafficking. And the idea of focused ultrasound ablation would certainly be appealing in breast cancer, given the ease of access of many of the tumors being fairly close to the skin surface and with no air interface in the way. So this is the background work that's led to our ongoing clinical trial. And so the work shown here is done by Rich Price and Tim Bullock. And the reason this was embarked upon is that the immunology world in breast cancer has known for quite a while that checkpoint inhibitors and other therapies in at least estrogen receptor positive breast cancer have been a spectacular failure. And one of the leading explanations for the failures of immunotherapy in ER positive breast cancer has been a myeloid population of cells that exists prior to the application of immunotherapies. So our group's approach to trying to better understand myeloid suppression in breast cancer was to look at the 4T1 mouse model, which is well known to be a immunogenic model and one with a strong myeloid response to immune therapies. We implanted tumors, and you can see the water bath focused ultrasound set up for the mouse models. This very nicely and elegantly mirrors the human setup in terms of power and depth and ability to do sparse style ablations as we do in humans. And so you can see some of the work done in the lab. And again, I'm abbreviating everything, but here's a setup of the ablation zones in a 4T1 implanted tumor. Here's an example during treatment with a ultrasound mark during the treatment. And here you can see some of the explanted tumors from a sham-treated tumor, which is quite blue with no necrotic areas. And then you can see the nice paler necrotic areas in the ablation cavities where you lack the bright blue 4T1 tumor cells. So the group confirmed that they were able to achieve ultrasound ablations. More interestingly, we looked at some of the myeloid cells and in plus-treated 4T1 tumors. You can see that there's a significant elevation in dendritic cells as well as CD86 positive type suppressor cells, and not a significant change in Tregs in plus-treated tumors. And then more interestingly, on careful analysis of subsets of myeloid cells, Dr. Bullock observed that the biggest change seems to be in the granulocytic type MDSCs. Next, we reached into our toolbox of myeloid targeted therapies, and certainly there are many up and coming myeloid targeted drugs such as the CSF1R inhibitors. But ultimately, when we thought about what we could take into our clinic the very next day, the obvious choice was gemcitabine as an older chemotherapeutic drug, which has fairly broad activity against all subsets of myeloid cells and some activity against T cells as well. We then used the 4T1 model we just described, and we treated the mice with either sham, FUS alone, gemcitabine alone, or the combination of the two. And you can see the tumor explants shown here, and you can see tumor volumes on these explants. You can also see caliper measurements over a 40-day experiment. And not surprisingly, sham-treated 4T1 tumors grew out fairly exponentially by around day 20. And then the FUS-treated animals had slightly delayed outgrowth, but still grew. Gemcitabine as a chemotherapeutic certainly delayed outgrowth, but did not abrogate it. And the combination of FUS and gem had the best response. It was more than 30 days before we started seeing tumor outgrowing. Not surprisingly, on the Kaplan-Meier curve, you can see that this kind of. Now, we did several experiments in the lab to verify the immune modulation, and I don't have time to show all of them, but I think one of the most telling experiments is to repeat the exact same experiment in RAG1 knockout mice that lack T and B cell response. And so, not surprisingly, in the RAG1 mice with no T cells, plus gem really didn't work when there wasn't a way to modulate the immune control of these tumors. And so that's sort of a verification that the gem is working not just by its cytotoxicity broadly, but more specifically by its effect on myeloid cells. So to prepare for a human clinical trial, we used the Theracleon echo pulse device. This is ultrasound guided ablation. It's already met European Union health and safety standards. It's been used to treat fibroadenomas, and it's been used in 2 other clinical trials at the University of Virginia. Our rationale was to study the effects of gemcitabine FUS or the combination on MDSCs and T cell phenotypes and functionality in early stage breast cancer, with the hypothesis that we would decrease circulating and intratumoral MDSCs and perhaps increase circulating effector T cell responses. We designed a 3-arm randomized study for gem, FUS, or the combination of the two in early stage high-risk breast cancer. And we're doing this as a window of opportunity trial in the 3 or 4 weeks that it takes from diagnosis to get to lumpectomy or mastectomy surgery. We tried to design it so that we could do the FUS treatment at the exact same time that a standard preoperative sentinel lymph node biopsy would be done to hopefully prevent patients from needing 2 rounds of anesthesia or extra visits. So trying to make this a more appealing trial for early stage women, since obviously it's very scary to be told you have breast cancer, and throwing in a clinical trial is even more stress for our accrual efforts. At any rate, we would treat the patients that would go on to standard lumpectomy or mastectomy and could receive whatever standard adjuvant therapies, such as the adjuvant chemotherapy, which most patients would be expected to get anyway, or radiation or endocrine therapy. And we would follow the patients for 5 years to see what happens in terms of recurrence and overall survival, although those are purely exploratory. And we will collect sentinel lymph nodes for immunohistochemistry as well as nucleic acid analysis, and we'll have the benefit of comparing tumor tissue at the final lumpectomy or mastectomy to the prior sentinel node tissue. We'll also have the baseline biopsies, and we will be able to look at research bloods on days 1, 8, and 22 as listed below. Inclusion criteria will be newly diagnosed breast cancer from stage 1 to stage 3 with high-risk features, and any receptor status would be eligible. If a genomic profile such as a mammoprint or oncotype is done, they'll have to be high risk, have to, of course, be accessible to FUS ablation, and willing to provide tissue and willing to undergo the procedure as well as a standard lymph node biopsy. The exclusion criteria are the receipt of any other treatment for their current breast cancer, pregnancy, immunodeficiency, allergic reactions, breast implants in the way of the FUS application, known infections, or other complications. With that, I would like to thank my collaborators, Dr. Tim Bullock in the Immunology Labs at the University of Virginia, David Brennan from Surgery, Dr. Alex Matthew in Immunology, and Bethany Horton in Biostatistics. Thanks.